Hello and welcome back to another episode of the Core Consult RX podcast. And this is not an accredited episode. However, we do have one of our favorite guests. Cole and I are joined by Dr. Bernard Best. Bernard, what's up, man?
What's up, man? Fan favorite. It's good to be back.
Good to have you, man. I just realized I had the wrong video started on there, but we're good. We're just going to keep rolling with it.
Yeah, we're here. We're here.
We're here. So what's new in your world?
Man, I'm finishing up PGY2 residency.
There it is.
Just looking forward to contracts, negotiations, discussions, all that good stuff. Yeah, and just kind of transitioning out of like being a student, being a resident, being all these things, and kind of getting back to life and figuring out life. So
about to be the main guy.
Yeah, something like that.
How has the hours been with PGY2? They've been working you to death, or you feel like you still have some kind of social life and stuff?
Yeah, I definitely still feel like I have some social life. It's
Good.
a lot more reserved, a lot more lax than PGY1 was. PGY1 back in Utah, it was very demanding, but I learned so much when I was there. PGY2 hasn't been quite as demanding, but I've still learned a lot this year. But a lot more flexibility, a lot more targeted as far as like me not having to go into the ICU and do different things like that. It's AmCare PGY2, so I'm just AmCare.
What's been your like favorite rotation so far?
I would have to say what I'm doing right now. So sickle cell and the topic that we're talking about today, sickle cell. I think a lot of the things that I've done in the past, like heart failure, I've enjoyed them. I've done them again as a PGY2, even though I've done them as a PGY1 as a student, and as a student. But yeah, sickle cell has just been something new that kind of gives me the opportunity to hop into a disease population that's pretty niche, and also still it's a primary care clinic as well, so I'm still seeing like diabetes, hypertension, all those things. So very big playbook as far as the drugs and the recommendations you get to make.
Yeah, that's awesome. Yeah, that's definitely a very important like patient group that I feel like we don't oftentimes have kind of at the forefront.
No,
but
for sure.
yeah, I saw some of the sickle cell patients when I was working my last job, and yeah, some of those patients have a very, very hard quality of life.
Yes.
So that's awesome that they got you down there. You thinking that's going to be a going forward plan if you can?
TBD. I don't want to, knock on wood. I don't want to jinx anything.
Yeah, that's awesome.
Yeah, we're looking.
Sorry, Cole, I didn't mean to cut you off.
I was just going to see where he was at in Utah while you were there.
Oh, yeah, I was in Salt Lake, man. I was at the University of Utah.
Nice.
Yeah, shout out to my people out there. Abby, I know you might be listening.
Did you do all the hiking?
Oh, I did, man. I did every hike that I could have done. Yeah, like Utah's nice because you can go 5-10 minutes and you're on a different hike. You're at a different ski resort, different snowboarding. Yeah, all kinds of different stuff. So
it's a cool place. It feels like you're on Mars when you're driving around. It doesn't feel like you're.
Yeah, I agree. It's
in a normal
gorgeous.
Place.
Yeah,
it's pretty cool.
Very cool. I definitely, that'd be one of, if I was going to move from South Carolina, that would definitely be one of the spots I would look at.
Yeah.
Because, Utah's nice.
Yeah, and their hospital is legit.
Yeah.
Yeah, it's legit.
Hardcore.
Yeah.
That's good, man. Well, we're glad to have you back. And we're doing, like you said, a sickle cell patient case today. We had a lot of people that wrote and said they liked the last patient case that you and I did. So
okay.
Yeah, so I'm excited to do another one with you.
Word.
And then I'll upload the patient case, like some of the highlights and stuff if people want to follow along.
Okay.
I'll put that on the website if that's cool with you.
Yeah.
And
sure.
And we'll just kind of let you start things off, and Cole and I will chime in if we have any 2 cents.
Okay.
Just so we can sound like we're a part of it.
Yeah, that sounds good. I guess I just want to kind of open up with that. I've been in this clinic for 2 months. This is kind of my first experience working in any kind of like hematology based clinic. So I definitely don't know everything there is to know about sickle cell. I've been learning in the 2 months that I've been there, 2 going on 3 months. So there's still things that I'm, even with the providers we're working on, we're learning every day about the literature and everything in this patient population. The guidelines are very outdated. There's not a lot of guidance. And so sometimes it can feel like the Wild West. But we try to use all the literature and all the data that we have. But I just wanted to give that disclosure that I'm not a 10, 15-year expert in this disease state.
Oh, dude, you're going to fit right in with us. That's how we are for every episode.
Yeah, I have learned quite a bit being over there.
That's awesome.
Yeah.
So what do you want to start off with? Do you want to go through the case? Do you want to give some background?
Yeah. I'll give a little bit of background about the pathophys of sickle cell and then some of the drugs that we might use in this patient population, just to kind of give the audience some context. I won't spend a ton of time on it, but I just want to make sure everybody kind of feels they have some baseline knowledge. So just kind of diving right into the pathophys, thinking about what we're looking at in this patient population. It's going to be, again, a hematology thing. It's about the red blood cells. So the red blood cells, essentially, they're responsible for transporting oxygen throughout the body whenever there's demand, whether it's the muscle, you're exercising. Red blood cells are responsible for transporting that oxygen throughout the body. Within red blood cells, there's a protein called hemoglobin that holds the oxygen molecules and is responsible for the transport. And essentially, when in sickle cell, when their hemoglobin, these proteins release the oxygen, it causes polymerization and sickling of their red blood cells, just because they have this genetic abnormality. But yeah, essentially, yes. When patients the oxygen is being released from the hemoglobin protein, that's when the sickling occurs in these patients. And when these long rigid polymers begin to form, they can cause vaso-occlusive crises, which is why these patients experience pain. And they have a slew of different comorbidities that pop up in this patient population that I'll dive into in just a second. But essentially, they have sickling all throughout the body, vaso-occlusive events all throughout the body. And so pretty much any organ can be impacted by the sickling.
And even when they're not in a pain crisis, a lot of times they're still dealing with pain on a day-to-day basis, which I feel like is something that gets kind of overlooked sometimes.
Yeah. So there are different levels to pain. So anytime patients are coming in, I'm definitely asking like, hey, are you in any pain today? Where is it at? Is it in the legs? Is it in the arms? Is it in the bones? Is it in the joints? Is it in the muscle? And how bad is it out of 10? So we can kind of try to track along like with the interventions we're making, like have some sort of semi-objective way to measure pain, because there isn't an objective way to measure pain. Maybe looking at heart rate and blood pressure and those kinds of things, but those are dynamic.
Yeah, it can be very subjective.
Exactly.
Like me, a credible pain tolerance.
Yeah.
No. But yeah, no, I can't imagine like dealing with that on a day-to-day basis. Like,
yeah.
I think their version of pain is probably something we can't even imagine.
Yeah, for sure. And you see in patients being admitted for 14 days solely for pain. So it's definitely a real condition. But I think being a pharmacist, I'm able to kind of teach them about different options like gabapentin, augmenting, muscle relaxers, different things like that. Which I'll get into in a little bit. But in general, that's the kind of the pathophys behind the disease. And then when it comes to the complications that you can see here, again, vaso-occlusive crises all throughout the body. So you can see stroke. You can see something called acute chest syndrome, which is more of an inpatient thing. Patients typically will get antibiotics with acute chest syndrome and get fluids. Can also see retinopathy, something called avascular necrosis, which is a pretty interesting complication where essentially the blood vessels that supply blood to the femoral head in the hip, they become occluded and you can no longer supply blood to the hip. And patients essentially have collapse of their the bones in their hips. And so they'll have to get a hip replacement. And this can occur even at the age of 25, 30, pretty young ages where we can see patients needing hip replacements.
30 years old getting a hip replacement.
Yeah. And
that's wild.
Typically we'll need the one every 10 to 15 years after that.
Jeez.
Yeah. Really?
Yeah. It's pretty crazy. Like I can say at least once a week, if not multiple times a week, we have somebody in their 20s or 30s that has like a crippling, debilitating walk.
Jeez.
Just because of the vaso-occlusive events that occurred in their hips. And then also DVT, PE are things that we still have to worry about. Pulmonary hypertension, more like a CTEPH picture. Priapism is a complication we see in sickle cell. Ulcers, specifically lower extremity ulcers. We see nephropathy. And we also see something called iron overload that patients can develop after they've had transfusions. And interestingly, we see a lot of vitamin D deficiency. And I don't know if this is something that's pretty common amongst all primary care patients and we're just not screening for it, but a lot of vitamin D deficiency in these patients. As far as other things to kind of think about, there are different subtypes of sickle cell disease, which will correlate with how much sickling that you see in these patients. And so there's hemoglobin SS, which is typically thought of as the most severe form of sickle cell disease, the most sickling, the most vaso-occlusive events, the most pain. But that's not always the case for every patient. We see some that have SS that are maybe not as severe, some that have SC, which is a different form of sickle cell. So yeah, and how that's determined if they're SS or SC is based off of their variant. So there's different types of hemoglobin. So essentially you run a lab and figure out what percentage of their hemoglobin is S or C or any of the different types of variants. But yeah, nonetheless, there are different types of sickle cell disease, with SS being typically the most severe form. And then before we hop into the patient case, I just want to quickly go over the drugs that we see in sickle cell disease. Even though we might not talk about all of them today for the patient case, I just want to make sure that we cover them at least briefly. One of the main drugs that people hear when they think about sickle cell, what is one that you guys think of?
Hydroxyurea.
Oh yeah, the big.
First of all, Bernard, do not try to quiz us on our podcast.
I'm just trying to keep y'all keep y'all in the loop.
Hydroxyurea should be first line if possible.
Yeah, for sure. So this is a medication that raises one of those hemoglobin variants. It's specifically a fetal hemoglobin that we have whenever we're born, but we lose it as we are no longer a fetus and we grow into an adult. But it also helps break up some of those polymers that form from the hemoglobin releasing the oxygen. So hydroxyurea is something that's been around for a very long time and has been shown to increase that fetal hemoglobin and reduce vaso-occlusive events. There is monitoring that we have to do with hydroxyurea, specifically the neutrophils, platelets, reticulocytes, different things that we have to keep in mind for monitoring hematologic toxicity. But nonetheless, it's one of the first things that we think about whenever we think of sickle cell. A couple of new medications have come up in the past 5 to 10 years. So glutamine, or the brand name is Endari. This is essentially an amino acid that works by reducing oxidative stress in the red blood cells, which has a trial that is shown to reduce vaso-occlusive events for patients that have had 2 or more admissions in the past year. Another medication is called Oxbryta or Voxelotor. This one increases hemoglobin's affinity for oxygen and reduces the amount of sickling in red blood cells. There is also a monoclonal antibody. Oh, excuse me. Let me go back to Oxbryta for just a second. What we typically see in the trials with Oxbryta is that it'll raise hemoglobin by about a point. So this is more so for patients that are dealing with like chronic transfusions. You really think about getting Oxbryta on for them.
Because it wasn't statistically different for pain crises, right? In this
not necessarily. No, it wasn't. Yeah, whenever they did the analyses, it's not really something that we look at for Oxbryta. Whenever I'm looking at it in clinic,
trending. I think it was trending towards a reduction in acute pain episodes, but didn't reach statistical significance. Yeah, so that's a bummer. But yes, definitely good for the anemia aspect. Yes, hemolysis
for sure. The next drug I was going to mention is called Adakveo or crizanlizumab. This inhibits a protein called P-selectin, which is essentially involved with adhesion to blood vessels. Not one that I've seen a ton in clinic. There's been some studies that have been done in other countries that have said, maybe this drug isn't as effective as we thought it was. But originally in the big trials that we saw over here, we saw like 50% reductions in crises. I think the difficult thing with analyzing this specific patient population is like ED utilization and hospitalization. Sometimes those things can be for nausea, vomiting. They can be for muscle spasms, which may not be necessarily directly related to their sickle cell pain, or it could be headaches that they think are related to their sickle cell pains, and that could cause an ED visit. So a lot of the times when we're analyzing some of these studies, you have to kind of keep that in mind that some of the things are subjective. But on to the next drug. So the next one is Jade or X-Jade. This is a medication that's used for iron overload for patients that have received chronic transfusions. For patients that get chronic transfusions, you get a ton of iron, which can be toxic to the liver specifically, but also the heart, the pancreas, I believe the thyroid, and a lot of other organs. So Jade News is something that's used to reduce the iron levels. We typically monitor ferritins for patients that are on Jade New. Pain management typically is going to involve opioids, but one of my big things that I've been pushing for as I've gotten to the clinic is non-opioids. We also do have transfusions. And lastly is folic acid for patients that are having hemolysis and maybe more of that macrocytic anemia. Folic acid is something that we look at. Typically, we just have patients go ahead and start it just in case. Just kind of
It's not going to hurt anything.
Yeah, it's like a multivitamin.
Yeah.
But yeah, just wanted to give some background and patho and a little bit about the drugs before I hop into the case. Any questions about anything?
No. I was just going to mention if you didn't see our last episode, we did briefly discuss at the end the 2 new gene therapies that are approved for treating sickle cell, but they're a little pricey.
They are very pricey,
in the millions.
Very pricey.
Yeah, check that out if you haven't listened to it yet. But yeah, the ones that he mentioned are definitely the go-to options. Is your clinic using crizanlizumab?
We have one patient that's on it. We have one patient that's on it. I haven't seen any other ones, but again, I've only been there for a couple of months. There have been some people that have tried it in the past and said either it didn't make a difference or it caused like increased pain initially, and then they just kind of stopped it. And there is a specific reason that some of the patients experience pain with Adakveo or the crizanlizumab. The hematologist that we work with was describing it one day why it initially causes this acute pain, but then I think it resolves after like the first couple of doses. So they just kind of have to work through it. I don't remember the specific mechanism. If I can figure it out, I'll have to I'll have to look through my notes and see if I can figure that out. But yeah, I don't see a lot of patients that are on it.
Yeah. I haven't heard of many, at least locally.
Yeah.
And all of these two can be used in combination with hydroxyurea as well, or without.
Yeah. When it comes to the gene therapies, I think there's some drugs that have to get pulled off.
Yeah. The gene therapy is different, but as far as the actual medications, though, right? Yeah, with or without, because I think that's something that can get confusing.
Yeah.
The gene. I don't anticipate seeing the gene therapies myself anytime soon. So I'll put those on the back burner.
Yeah, and when I looked into some of the studies that look at the gene therapy, there's a lot of side effects from from those things. So I don't know enough about it to like confidently say like, oh, I think this patient would be great.
Yeah.
But I think in the future,
I'm sure anytime we're using CRISPR to change our genome, I feel like
something's
there's
gonna
have some
something's gonna happen.
There's gonna be something we have to get some bugs out.
Yeah, something's gonna happen. But yeah, Cole, any questions before I hop into the case?
No, I am following you perfectly.
Sweet, awesome.
Good job, Cole.
Thanks.
So this case is a 48-year-old female with a past medical history that's pretty robust. So she does have history of acute chest syndrome, low back pain, anxiety, asthma, bipolar disorder, coronary artery disease, depression, DVT, history of transfusion, a gastric ulcer, a heart attack. And sorry, I'm not going in order. I'm going alphabetically. I would have put CAD with heart attack, but I'm just going alphabetically.
You're good, man.
Hypertension. She was intubated at one time during an inpatient stay. She had a small bowel obstruction. Obviously, she has sickle cell disease. Her variant is SC. She had a stroke in 2005. History of substance abuse, thyroid disease, a TIA, and just venous disease that is listed. And I just pulled this directly from her problem list. I didn't go and investigate every single problem she has on her problem list, but those are all the things that she has. As far as her family history, her mother has sickle cell trait and depression. Her father has sickle cell trait. And then her maternal grandmother has diabetes, colon cancer, and breast cancer. Maternal mother had sickle cell trait. Maternal mother had sickle cell trait. Maternal grandfather had diabetes, stomach cancer, and sickle cell trait. Her daughter and son both have sickle cell trait, and then somebody had a clotting disorder, but they didn't specify who that was. As far as social history, she has a history of smoking, 22.5 pack year history. She does not currently smoke, but there was marijuana that had tested positive on one of her drug screenings before. It's a common thing that we see in this patient population, especially with having as much pain as they do. So it's not something that the providers are as strict on as other things like amphetamines or maybe cocaine whenever they're not supposed to have that in their urine drug screen. But moving on next to her current medications. So this is just what was on her profile. She had albuterol, aspirin, butalbital, acetaminophen, and caffeine or Furoset for headaches. She had clopidogrel, 75 milligrams once daily, Benadryl, 25 milligrams once daily, folic acid. She had Dilaudid, 8 milligrams every 4 hours as needed, and a multivitamin. She also did have a Narcan prescription. She had nicotine gum, 4 milligrams. She had OxyContin, 40 milligrams every 8 hours. Miralax, some Phenergan, and a Qvar Ready Haler. And then she also did have glutamine on her profile, which is one of the medications, the Indari, 10 grams twice a day. As far as...
Was she actually getting that or taking it?
She wasn't.
Oh, yeah.
Yeah, she wasn't. Yeah.
That's the exact same situation
Yeah.
I've run into a couple times. Is like it's on their profile and they've never gotten it once.
It was from back in 2022, and she had never gotten it from specialty pharmacy.
I gotcha.
Yeah. As far as her vitals, blood pressure had ranged anywhere from 103 to 125 systolic over 49 to 90 diastolic. 49 is kind of low, but she's never really had any blood pressure issues. As far as general monitoring, we always look at CBC and reticulocytes just to keep an eye on things. For her, there wasn't anything that was too out of the ordinary. Her hemoglobin, her last two were like 9.6, 8.9. Platelets were in the 300s. Neutrophils were around 5. Her reticulocytes were pretty low, around 53 and 39. And those are just reticulocytes are essentially just markers to show if the body is trying to make new red blood cells. So if we see that reticulocytes are very high, that might indicate that this person is having some hemolysis. They are, trying to make red blood cells. But if it's really low, it's not necessarily a bad thing. But if we see that they're anemic and it's low, then that can be a really bad thing because you don't have any blood in your body, and your body's also not trying to make red blood cells. So it's like an aplastic anemia type picture. As far as her kidney function, we always look at that just because that can be a complication of sickle cell disease, as I mentioned earlier. But EGFR is looking pretty good. Creatinine less than 1, ranging like 0.6 to 0.8. Potassium's fine, anywhere from 3.8 to 4.6. Her last microalbumin was 8. That was back in 2022. That's typically what we use every year to monitor for any kind of kidney disease in these patients. Liver disease, any hepatic screening, everything was fine there. Her ALK phos was 81, but everything else was pretty much within normal limits. Her ferritins that we monitor for iron overload were fine. They were like in the 80s, 117. Typically, we think about starting any type of therapy for iron overload if the ferritins are greater than 2,500, and hers are around 100. So she definitely doesn't have any iron overload going on. And then as far as a sugar standpoint, this patient had a blood sugar that ranged anywhere from like 95 to 81 on her BMP, CMP. Interestingly, with this patient population, you cannot use A1C just because of their hemoglobin. It's a hemoglobin A1C, and these patients have abnormal hemoglobin. So the A1C is typically going to be off. I'm not sure if it's going to be over or underestimating, but typically we use the fructosamine to estimate what a patient's A1C would be if we did draw A1C on them.
And there's a conversion that you can use, right?
Yes,
like
there is a calculator you can use. Yeah. I'm not sure what the rule is, but I have the calculator.
Yeah, that's plenty.
Yeah. But I think when they get into the 400 or 500s is when they're getting kind of sweet, like maybe like 9s.
Getting kind of sweet.
Yeah, one of my preceptors in Utah said that.
I like that. I might steal that. Yeah, that's pretty good.
Yeah, I forgot who said that. Yeah, I think that was Wayne. But yeah, lipids, she's looking pretty good. Cholesterol, HDL, or total cholesterol, HDL, LDL, all looking pretty fine. Trigs, 46. And again, I'm going through all these things because this is essentially a primary care visit. So I'm trying to I have a note where it pulls all this data in for me. So I'm not really chart reviewing. It makes it pretty easy. But I do want to make sure I don't miss anything for comorbid conditions or any just general primary care things in addition to the sickle cell. As far as other things that are relevant in labs, in her urine tox, again, I mentioned earlier she had the positive cannabis screening that was back in 2023. It hadn't been positive since then, but nothing else concerning in her urine drug screen. And then I also looked to see for these patients, do they have any of these complications already established in their sickle cell disease? So look to see if they have history of stroke. She does not.
I thought she did have a stroke. No.
Oh, yeah, she had a TIA. I lied. She did have a TIA. So she had a CVA, but not a stroke, but CVA for sure. The reason that that's important is because for patients, specifically patients in the sickle cell population that have strokes, whenever they're a pediatric patient, they get transfusions typically monthly for life. So that's more so the reason that I look for that if they've had history of a stroke, because then it makes me look, okay, are they getting regular transfusions? But this patient wasn't getting transfusions. I think the TIA that she had was could have been related to her sickle cell. I didn't look into the neurology notes or anything like that, but she wasn't receiving any type of transfusions for the history of her stroke. But she, yes, did have a TIA. This patient, I don't think she had any ophthalmology with MUSC. She didn't have any documented retinopathy, but she, like a lot of the notes from the past just said, encourage yearly follow-up. So sometimes I'll just even recommend like, hey, do we want to get this patient in with opto, even though it's not necessarily a medication thing. Avascular necrosis. Yes, this patient does have some AVN, which is just the abbreviation for avascular necrosis. The last imaging that she had was in November of 2023. Basically what they said on the imaging was that there was unchanged radiographic appearance of the left femoral head. She does have AVN without collapse of that femoral head. So that just means she does have some necrosis, she does have some necrosis. She does have some sickling in her hip, but it hasn't completely collapsed to the point where she needs surgery yet. She has had a DVT or /PE. She is not on anticoagulation. She is on DAPT for her subclavian stent, and she also does have CAD with a history of a heart attack. I talked with a provider about this. Like, does she need to be on anticoag for the DVT-PE and maybe knock off aspirin? It wasn't one of the major things that we talked about today, but I think it's something that I put in my note that we need to make sure we reassess. Yeah, we can't in these primary care visits. There's so many things that you can talk about. But yeah, she was on DAPT for the stent and for the CAD, so I felt semi-comfortable with her being on something and us reassessing at the next visit. As far as pulmonary hypertension, that's another thing that we work up for these patients. And what we do for that is we look at an echo. And in these echoes, we look at the right ventricle instead of the left ventricle. For pulmonary hypertension, we're thinking of, is the right ventricle going through any type of strain because fluid's backing up on that one? But we still do sometimes find things in the left ventricle. For this specific patient, we saw that her left ventricle was normal. In her right ventricle, she did have some mild dilation, but nothing like super concerning. She wasn't really complaining about too much shortness of breath. She did have a diagnosis of COPD that was recently given to her in the ED. But as far as a pulmonary hypertension picture, she wasn't really having too many symptoms of pulmonary hypertension, no edema or anything like that. That would also kind of maybe indicate that she's having pulmonary hypertension. Priapism is something that we try to always ask about, but she's a female, so we don't have to worry about that. No history of ulcers, no history of nephropathy, but we haven't reassessed it on a yearly basis like we should. Again, that last screening was in 2022. And then for vitamin D, she was a little deficient with a vitamin D of 9.7 in December of 2023. And then lastly is vaccines. She's had Tdap, flu. She's had a variety of flu vaccines, but hasn't necessarily had the vaccines that are necessary for sickle cell patients, like the Haemophilus influenza type B, meningococcal, both the ACYW and the MenB, and then Prevnar 20. Those are some of the big ones that we look for in this patient population, and she hadn't had those. But yeah, assessment and plan.
Hey guys, I'm sorry to interrupt the episode, but I wanted to tell you briefly about our sponsor, Freed AI. Do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you are shaking your head yes, keep listening. Freed is an AI scribe that makes charting go away. It does your notes for you. Freed listens, prepares your notes, and writes patient instructions. Charting is done before your patient walks out of the room. Freed learns your style over time, just like a human scribe would. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. You can try 10 notes for free, and after that, it only costs $99 per month. You can find out more information at their website, www.getfreed.ai. Check them out today. Back to the show.
So how I've structured my notes is to first talk about the disease-modifying therapies. So again, this patient was SC, and she was currently not taking anything, not even folic acid or the Yandari that was on her profile. Prior to this visit, this is just other things that I include in my plan, just what happened at the last time. So at the last visit, we just stopped fluconazole and Effexor, and patient was being seen by ID for some infectious workup that she was going through. But since that visit, the patient had only been to an acute visit, which is just an outpatient IV pain treatment. She'd only been to one of those one time, and she'd been to the ED one time, and that was for chills, cough, congestion, and some sickle cell pain in her legs and back. And she hadn't been admitted at all. Her most recent admission was back in January for 6 days. This patient did have 5 admissions in the past year, which is something that I try to look at whenever I'm thinking about making a medical decision as far as initiating a new therapy. I say, hey, how many times has this patient been to the ED or been to the hospital in the past year for an admission? And she had been admitted 5 times in the past year. And so I thought at that point it's reasonable for us to add on a disease-modifying agent, whether it's going to be hydroxyurea or Andari. That's kind of what I talk about with the patient and do more chart review on. So upon talking about hydroxyurea, she was absolutely no. She was not one to talk about it. She had side effects in the past. I believe she had hair loss with it, which is one thing that we can see with hydroxyurea. Hair, skin, and nails are some things that we do see impacted. Specifically, we see like when you shower, you might see a little bit extra hair come out, or you might see some darkening of the nails. And some people have like skin ulcers on their lower extremities. In that event, we would typically stop hydroxyurea. But for her, it was the hair. And so she was not willing to even talk about discussing it. And so I kind of flipped over to like, hey, let's talk about Andari or the glutamine. And so I've made a handout, and I handed her the handout and talked about, what it's for, how you take it, how it benefits, side effects, and all those things. And she ended up agreeing to start the Andari, which was a win. She didn't even remember it being on her profile. So it's good that we, were able to get her back kind of coached up on it and how to take it and everything. It is a powder you have to take twice a day. So I just talked about a few of those things with her.
Side effect profile is pretty limited, right? I mean, it's like mild GI, if
mild.
Anything.
Yeah, very mild. Like,
it's good.
Yeah. It's like Tylenol. Like,
yeah.
But yeah, she agreed to, it's weight-based dosing. So she would do 10 grams twice daily. They come in 5-gram packets. So she would do 2 packets twice a day. And then that was really the only thing that we did as far as modifying her sickle cell disease. The next thing I think about assessing is pain management. This patient today, she endorsed pain all over. She also did have some numbness in her right wrist that she said was from a port removal. This patient has been going through a lot with this previous port that she had in her like upper right, I guess, area, chest. I don't know anatomy. I'm not a provider, but she had a port, and when it got removed, there was a piece of it that somehow stayed in her, and after that she started having like different types of pain and having this numbness in her wrist. But that's a big stressor for this patient for sure. But yes, she complained nonetheless of pain all over her body and numbness in her wrist from that port removal. Her current medications were a short-acting dilaudid immediate release, 8 milligrams every 4 hours, and a long-acting of OxyContin, 40 milligrams every 8 hours. As far as non-opioid, she wasn't on anything at the time. I also do assess bowel regimen and antiemetic regimen. She had Miralax on her bowel regimen, and she had a Phenergan 25 milligrams every 6 hours PRN. And she also did have a Narcan, which is something that I try to assess for every patient that has opioids. As far as some of the historical medications, she did try gabapentin 300 milligrams 3 times a day as needed, but she said that it made her jittery and tired, which was interesting. But she was open to retrying it at a lower dose. She also did try Flexeril in the past, and she was open to restarting that as well, and she requested a refill. She did say that she goes about 3 days without stooling typically. And so we talked about starting a PRN, extra PRN for her bowel regimen. So ultimately for her pain medications, we went with adding on gabapentin 100 milligrams 3 times a day as needed instead of the 300 that she had in the past. And then we restarted Flexeril 5 milligrams 3 times a day as needed. And then we started Senna Docusate BID PRN. Yeah.
The bowel, prep is something I feel like is grossly overlooked a lot of times with constipation, and what people don't realize, not that they don't realize, but it's just something that they don't think about. They're trying to deal with the pain and all the other stuff that's going on, and the fact that you could have chronic constipation, especially with those kind of opioids daily. The Senna and the Miralax, Colace sometimes added in. But then there's also good data if that doesn't work and you need to, go, a different route or more hardcore route, I guess you'd say, instead of going like Movantik or something, because she's on the opioids and stuff. There's good data with Linzess.
Oh, really?
Yeah, with opioid-induced constipation.
Okay.
It's not FDA approved for that, which I think Amitiza is, but Amitiza is kind of a wimpy, med.
Yeah.
But Linzess does have some good data. It's just not, it's off-label use for that particular type of constipation. But I've used that for a few patients who are taking methadone for substance abuse disorder, and were having serious issues with constipation because of it.
That's good to know.
Yeah, Linzess was my go-to. Plus, your clinic qualifies for 340B, which is Linzess is dirt cheap.
You could see my head spinning. I was going to ask, what is the price of Linzess? Because I don't know.
It's getting a lot better coverage now. It's been out for a while. Now that they got Trulance and some other stuff, they're similar. But Linzess I haven't had any issues getting it covered, at least in my anecdotal
experience.
Is it generic? Not yet. I don't believe so.
Okay. Cool. Does it typically need a PA or?
I haven't had too many issues with getting it. Nah.
Okay.
Usually it's covered.
Good to know.
But I will say taking it 30 minutes prior to a meal is usually a good idea. Taking it with a meal, especially a high fatty meal, can increase that diarrhea side effect. Push it a little too far on the other end of the spectrum.
Yeah.
But that's one I've had success with in the past.
Yeah. Surprisingly, I haven't seen a lot of Movantik.
Yeah. Well, and I would think with the type of being on opioids constantly too, I would think that wouldn't be a great.
Yeah.
What about as far as the pain meds? Do you ever see methadone used instead of traditional opioids?
I see it every once in a while, not very often. But yeah, maybe I've seen 1 or 2 patients in the 2 months that I've been there that are on it. Sometimes in this patient population, you do run, with chronic use of opioids, you do run into an OUD picture, where sometimes you have to reassess, hey, are we doing the best thing for this patient, or do we need to reassess how we're managing them? And whether that's, looking at stuff like Suboxone or methadone.
Well, and I mean, even methadone is taking it more than just the once a day for substance abuse, but methadone, kind of taking it through other, because it has that
TID
and NMDA activity as well.
Right.
So I've seen some data with sickle cell patients specifically with methadone.
No, I've seen it used for pain, but mostly it'll be used for pain in the event that there is concern for OUD.
Right.
But yeah, we actually had addiction specialists come in 1 week and like work with us, and like it was really nice to have them there and like coach us through like Suboxone and different stuff like that. So that was really nice, and I hope we can have them on full time, because that's something that as pharmacists you want to make sure you're like not precipitating a withdrawal or like doing anything to harm the patient. So yeah, it's really nice to have like some people that are really experienced in that.
When you were talking to that provider, did they talk about cannabinoids as use or anything? Because I mean, I know that the data in sickle cell patients especially is very lacking.
Yeah.
And so there's been some studies showing it's beneficial for pain and other studies show it's not. But I'm curious to see their thoughts on it as far as using it for pain relief, whether it's OTC, so to speak, or whether it's in a state that is, allows it medicinally.
Yeah. That isn't something that I've specifically asked her about. She was only there for one patient, so I had maybe 20 minutes with that specific provider. So I was like, ooh, let me just ask these questions. But that would have been a really good question to ask her. But yeah, I will definitely have to write that down next time so I don't forget whenever I see her. Other things that we had talked about is like, Suboxone versus buprenorphine monotherapy, and kind of talked about that a little bit. And there's
like the Butrans patches or something.
Exactly. And coverage and like the strengths, like with buprenorphine products, they're typically a little bit less strong or less partial agonists that you'll get in those than as compared to like the Suboxone. A lot of the buprenorphine products are in micrograms, and the Suboxone products are in milligrams, like 2 milligrams.
And when you just like Suboxone is still buprenorphine, it's just a higher dose. Is that what you're saying?
Buprenorphine with naloxone.
With naloxone, but the naloxone's only activated with if you crush it or like try to inject it or something.
Correct.
Yeah, okay.
And then like Belbuca or the Butrans patch, those are just buprenorphine, whereas Suboxone has the naloxone with it.
Deterrent.
Yeah, and the reason that we kind of talked about it, because she was like, I don't want you to make sure you're not looping those together. I was like, I know they're different things, but the coverage for Suboxone is typically a lot better than things like Butrans, Belbuca.
Yeah, and Butrans is specifically for pain. I think that gets confusing a lot, because buprenorphine, mostly you're seeing it like in Suboxone form or Subutex even.
Yes.
But the Butrans is the one that's actually approved for weekly pain.
Exactly. So yes, there are buprenorphine, like single buprenorphine products that are approved for pain. There are no like Suboxone products that have an approval for pain, but they still do treat pain.
Yeah, right. And I guess because it's a partial agonist at the mu receptor, but then an antagonist at kappa opioid receptor, I guess that takes away some of the concern for respiratory depression and some of those types of
for sure
side effects, which obviously is concerning for someone who's having to use it daily.
Yeah, the thing that's so interesting about this partial agonist with the buprenorphine is that even though it is partial, it has a higher affinity than the full agonist. So patients that are on, full agonists like oxycodone, OxyContin, Dilaudid, whatever they're on, if you go and add in a partial agonist, it's not just going to like take it slow time, like, get in there. It's going to knock all of that other full agonist opioid off, and the patient's going to feel like they're going through withdrawal.
Yeah. Well, and I've seen people do that where they try to combine standard opioids with like something like buprenorphine. I'm like, that doesn't make any sense.
It doesn't work. Yeah. So you have to be very methodical in how you approach it. If they're on, and this is what we talked about this with the provider as well. But if they're on a very low dose, say if they're only on like, a PRN and they're only using it maybe once a few times a week, they can take their last dose whenever they, say if they had a dose at 8 a.m. and we want to start them on Suboxone, they can take their last dose that morning, and then by the end of the day, we could start them on Suboxone, just kind of give them a 12-hour washout. But if they were on, big doses of like short acting, and like they were also on a long acting, like this patient, she's on a long acting and it's not even 12 hours, it's up to 8 hours of her OxyContin. She would be somebody that we would more so do a micro induction, where we use like very, very small doses of the lowest dose of the Suboxone. We would probably have them like split the films up into like fourths. But it's been something that we are still trying to kind of figure out the kinks with. Been working with some different psychiatry pharmacists and just different providers to kind of get different recommendations, and just kind of be very patient with how we approach those. But we have had like 2 or 3 patients that have successfully transitioned over to Suboxone since I've been there in the 2 or 3 months that I've been there.
Who were dealing with substance abuse?
Control the same?
Oh, one at a time, boys.
Sorry, go ahead. Cole.
I was just going to say, was the pain control adequate? Was it similar?
Yeah. Pain control was similar. Yeah, really, it's kind of that first week of like either getting them like on a taper or like making sure they get the other stuff out of their system so we don't precipitate a withdrawal. But the two that we've gotten transitioned over have been,
done well.
Sailing. Yeah.
What you mentioned that she's on Furoset for butabitol, acetaminophen, caffeine. Do you know how often she's having to take that?
No, she did request a refill on it, but she is one of the. Oh, before I get to that, I wanted to harp on something that you did mention that's good to talk about. So with these patients, a lot of times we'll see it. They'll go to the ED 4, 5, 6 times a week, and so a lot of it they'll say, oh, it's related to sickle cell, but really it's they're on narcotics and they're having like nausea, vomiting, like constipation. So like, although these things seem silly, I'm like,
they're not.
Let's please just get the person an antiemetic. Please, let's get them a bowel reg just to like prevent them from needing to go.
That should be standard for anybody silly. On opioids. I mean, like that should be like, right? Like should go along with it, just like Narcan does.
Yeah. Like let's augment. Like if they need ODT, like let's not let that stuff like let's not forget about it. And I even coach the patients. I'm like, if you know you have nausea, take your antiemetic right when you take your dose or a little bit before. So yeah, just I tell them let's keep you out of the ED for silly stuff.
For sure.
But going back to your question about
the butabitol and the Furoset, basically, we don't know how often she's taking it.
No, I didn't dive too deeply into that. I don't think she had it because she asked me for a refill. She was going through a lot of like psychosocial stressors. And so I think she didn't have a lot of her medications, honestly. So I didn't dive too deeply into that.
Because that's something I always think about, especially in this patient. I would be like concerned because obviously with the butabitol, you can have like overuse, like medication overuse headaches, which then if she is truly having migraines, like there's such better medication like the G-Pants or the CGRPs, and those would be a much better alternative than something that has butabitol in it.
Yeah. Butabitol, that is a barbiturate, correct? Yeah, and I don't think she had any barbiturates positive on her UDS, so I don't think she was using it that frequently.
And honestly, I don't know how that shows up.
I've seen it
like phenobarb, stuff like that would be a lot more of a which pop up on a drug screen. But like the Furoset, unless it's the one that has aspirin instead of Tylenol, aspirin it's a control, but the Furoset's not even a controlled substance.
Right.
So I don't even know if that would trigger a, depending on what the threshold is. I don't know if that would show up or not.
Yeah.
But just that would be something just to have on. I would want to have on my radar, just because
that's a good point.
People use, and sometimes it's because it's not a control. They just refill it and don't think about the medication overuse headaches can definitely increase.
That's a good point.
Needing pain medication down the road. And
that's a good point.
Get knocked out with Gality or one of those other much better medications we have for migraines now.
Excellent point.
Just food for thought.
I'll go addend my note.
What about we kind of going back real quick about the cannabinoids, because I think that because there's not a lot of data and some people are really concerned, but I think the other thing to keep in mind with this patient in particular is the fact she's got all the psych disorders and the anxiety and stuff. She would be someone I would be normally. I'm kind of in the ballpark, especially in a patient like if just sickle cell by itself, I wouldn't be all that concerned if I saw THC on a drug screen. However, this patient dealing with anxiety, dealing with bipolar disorder, that would be a lot more concerning.
Especially
maybe,
if you're not getting it from like a controlled environment, if you're getting it off the street.
South Carolina is still illegal, so it'd be one of those things where I would say like maybe even looking at CBD possibly instead, just to see if not going to have the same relief necessarily, but that would be a patient that I would have a little bit more of a conversation with than a patient who doesn't have any of the psych disorders. I probably wouldn't even.
No, for sure. That's a very valid point. I haven't followed up on her labs yet from our most recent visit to see what ended up popping up in the UDS. But yeah, that'd be a good conversation to have. But I will get into her psychiatry condition in a little bit. But yeah, moving on to the next thing. One of the things that the patient kind of brought up in the room is that she was recently diagnosed with COPD at a recent ED visit. She had been seen by pulmonology recently, and they ordered a bunch of different stuff, echo, some PFTs. Ultimately, what they did at this visit was just start her on a 14 milligram NRT patch. And the patient said that she was diagnosed with COPD, but once she got the PFTs, her FEV1 over FVC was greater than 70, which isn't necessarily COPD. And so I was like,
how much does she weigh?
I don't know. I don't have that.
Is she overweight?
She's pretty light.
Okay.
Based off of her Endari dose, she was in
10.
her 50. She was in the 50 kilogram range. So she's not she's
okay.
a little teeny thing.
I was just curious because I feel one. Did they do spirometry in the ED or just from previously in pulmonology?
I think they didn't do it in the ED. I think it was after her pulmonology visit.
And do you say she is currently smoking or is it not?
She is. So she's currently smoking about a half a pack a day.
Okay.
And so as far as what she's currently doing right now for her breathing disorder. Currently smoking a pack a day. I guess that's not beneficial for her breathing. But she also had a QVAR and an albuterol nebulizer on her profile. And so
Yikes.
Yeah. So when she said COPD, I was like, okay, we definitely need to talk about switching from steroid and SABA over to maybe Sama Saba, Laba Lama products. But when I kind of did some more investigation on the LFT or on the PFTs, and saw that, maybe Palm needs to keep digging into this to figure out if it's actually COPD. I was like,
I'm just more restrictive than obstructive.
I'm gonna let them drive the boat. She's already with Palm. They're gonna do better than I can.
Did you say she had a history of asthma?
It was on her problem list. I asked her about it, and then when I talked to her, she was like, "I've never been told that I have asthma.
Oh, perfect.
Even as a kid, I've never been told that." So I think the problem list is kind of like how the drug list can be sometimes. Yeah. It's just kind of this collection of stuff
that people just didn't want to dig deeper.
They need a reconciliation.
Because I agree, QVAR would make no sense, but especially monotherapy. That's ridiculous.
So I definitely was like, hey, let's not refill this QVAR. I was like, if we want to refill her short acting bronchodilator, whether she has asthma or COPD, it's not gonna be detrimental either one of those. I was like, whatever.
Yeah, the QVAR I would definitely leave off.
No, but the QVAR I was like, absolutely not. We're not gonna refill that,
especially with her pneumonia risk and everything. Given sickle cell, that would be no good.
Yeah.
Has she ever been had a sleep study that you know of to see if she has obstructive sleep apnea?
I am sure that the referral has been placed. I don't know if she's actually done it. Yeah. Yeah, I can't say off the top of my head. I don't have her entire chart pulled up in front of me right now.
Yeah, that's cool.
But no, that's a good point.
Because that would be the other thing. If she did have something like obstructive sleep apnea and she has a history of maybe COPD or maybe whatever asthma, her obviously risk of respiratory depression. We always think about opioids, just somebody just taking too much, but we oftentimes forget someone with COPD or obstructive sleep apnea. They're going to be much more likely to have an overdose just because of that respiratory depression risk. Yeah. So that's the other thing I would kind of have in my radar just for future reference.
Good points, man. I still feel like a student. You're schooling me right now.
No, dude. I'm just chiming in.
This is good. But ultimately for her pulmonology condition, whatever she has as it continues to be worked up, I recommended refilling her albuterol. She requested a nebulized albuterol with the nebulizer device. I was like, sure, you can have that. I recommended sending in the 21 milligram strength nicotine patch. The cutoff is a half a pack. If you're over that, you can go to 21. Cigarettes. I was like, whatever we can do, let's just make it easy for her.
Has she tried the patch yet?
She had them at home, and when I asked her if she tried them, she was like, I have them, and then I went to the hospital, and then I didn't know if they had expired. I was like, they're still good. We're going to send the 21s just so you have them if you feel like the 14s aren't enough. Because they're covered on our insurance, and so I was like, "You have them."
She was on board with trying to quit?
Yeah, she's definitely on board.
Did she have nausea or anything when she tried nicotine replacement in the past?
She didn't mention it. She didn't seem like it was something that she gave a really strong effort for. She just kind of had the supplies at home, and she was like, "Oh yeah, I have those." So definitely we'll need some coaching. We do have a nicotine tobacco treatment team at MUSC. But I think we can definitely get her started off with the basics and make sure she has the stuff. And then once we see her and see that she is willing to use the patch every day, then we can get her in. But yeah, I don't think for a variety of reasons, Chantix would be a good option for this patient.
Talk to me.
There was it the Eagle study that they looked at for patients that have stable psychiatric conditions that you can use Chantix in. But as I'll show later when we talk about psychiatry, she had 3 psych hospital admissions. Was
it for mania? though? Or wasn't psychosis or anything, was it?
So it was for a bipolar. I didn't. So the provider came up to me after the visit, and like she kind of brought this up at the end. She's like, "Hey, the patient just told me like I've had 3 psychiatric hospitalizations. Like, I want to put her on an antipsychotic. What should I put her on?" So I went back through the chart to see like what has she been on before I just like randomly recommended something. And she was on Risperdal, so we ended up just like restarting that. But I didn't get the time to like work that up with the patient and really talk through it with her.
I imagine it was probably mania then.
Yeah, I would imagine it was mania. Yeah, but it could have been depressive depending on what type. But she had been on a variety of antipsychotics and different things in the past, and so we just got one thing on and got her back in with psych. But going back to Palm, got her the albuterol. We sent in the higher strength patch, refilled her gum. The patient still hadn't done her echo that pulmonology had ordered, so I was like, we need to make sure she does that. Or I recommended considering ordering a BMP just to see if she has any kind of like volume overload. So we talked about that. I don't think the provider ended up doing it, but she was like, "Oh, that's a really interesting idea. Like maybe." I have a lot more heart failure experience as I mentioned earlier, so I'm like, order that thing. Like we'll see. But yeah, I don't think she ended up ordering it. But yes, the bipolar was the next thing that I had on my radar. She again disclosed to the provider that she had 3 hospitalizations for psychiatry reasons that may have been mania or depression or a mix of the two. She was previously on risperidone at a variety of doses, on a few different drugs, but risperidone was definitely the most common thing that she had on her profile. The most recent dose that she'd had, I think, was from like maybe 2020-ish or 2022. And it was just a 1 milligram at bedtime. So we just kind of got that back on board and got her back in with psychiatry. And then other things is that this patient had history of a thyroid nodule that was on her problem list. I was just like, hey, let's order a TSH T4, just kind of see what's going on with the thyroid. So the provider was cool with doing that, and she also put a referral into endocrinology.
Did she ever have like imaging done after, or just found a nodule like by palpation, or like she actually had imaging done? Do you know?
I didn't work it all.
I gotcha. I'm just curious.
Yeah, I didn't work it up. She wasn't on any medications, and so like from a pharmacy perspective, I was I don't know how much I have to dive into this.
Yeah, no, I hear you.
And I had to get through all the patients.
No, I totally hear you. Yeah, I'm just curious.
But yeah, I was like, let's at least like the last TSH T4 she had was from 2017, so I was like, let's get some.
Yeah, just to make sure.
She had vitamin D deficiency, as I mentioned earlier. This is something that we've still been trying to figure out the best way to approach. Looking at some of the dosing in Lexicomp, whenever they're deficient, so like they're actually less than 30, they need like either 50,000 a week or of D3, or they need the equivalent daily, which would be about 7,000. And then we've also been debating like, do we need to always supplement calcium with vitamin D or not necessarily? So the providers have been doing calcium with vitamin D, and then so I just recommended doing like 25,000 units, like kind of like a maintenance dose. But I think moving forward, if we don't see people coming up, we might start bumping out the doses of the vitamin D until we get them above that 30.
Like the once a week.
Yeah, either the once a week or the 7, like a 6,000. I think it comes in 6,000.
Yeah, I don't know where the study came from, but one of the providers that I was talking with one day at UAM basically told me that there was a study that showed that the 50,000 unit a week, once a week, increases the risk of falls versus daily vitamin D. And I would think that this patient population, especially with the avascular necrosis risk, that may be a bigger concern than it would be with just an average person.
Yeah.
I don't know. Food for thought again.
Food for thought, yeah. I don't know. I know Dr. Bragg has also brought that up when I was a student about like the fall risk. And I don't know if that's more so when they are like, when it gets to the toxic levels, like if you're over 30 and you keep giving them 50,000.
Yeah.
I think that maybe, but don't quote me.
I'd have to look it up myself.
Yeah. But yeah.
No, it's definitely.
We're still trying to figure it out.
Yeah.
Other things is her avascular necrosis. She had recently had imaging, and so we just referred her to occupational therapy. And then this patient has the CAD, heart attack. She has a subclavian stent. That wasn't in her problem list, but she did also have that. Had the TIA, just a lot of vascular things going on. So we talked about cardiology referral, but amongst all the other 20 things that we talked about, we ended up making like 22 interventions in this encounter. And so that wasn't one of the things, since it wasn't like a problem that we were like treating today.
Yeah.
We didn't make a intervention on that today or like make a new referral, but it's worth definitely getting her back in with vascular or cardiology moving forward.
And she's been on the aspirin and clopidogrel combo for a while.
So the heart attack is in her chart from 2005.
Jeez.
But there's no, her first epic encounter that it was documented in was from 2007. So it's kind of one of those muddy things.
It's hard to figure out where it came from.
If it's been past a year for CAD, she definitely only needs one, but depending on how vascular might have viewed it, it could have been a surgeon that says we need both for life, and I don't want to step on any toes.
Especially if she had the TIA on top of it and all that.
Exactly.
That may be
a
different story.
Yeah.
And her blood pressure's been controlled for as far back as...
Yeah, her blood pressure's been pretty fine. She hasn't had any issues with her pressures, or, we would also see kidney things potentially impacted. Her kidneys look great.
And she's not on a statin, I guess, with an LDL as low as it is?
No, we don't see... I haven't seen a lot of statin in these patients. No.
Well, I'm just thinking, like, just given the things, since she's had ASCVD, but also her LDL is like in the 60s, wasn't it? Like, that's pretty low for not being on anything.
Yeah, it's not.
It's interesting.
Yeah, I remember... I forgot which preceptor was telling me about how, like, some of the patients here in Charleston, specifically African-American patients, they have, like, really high HDLs and really low LDLs without, like, just at baseline. But yeah, with her having like a history of like CAD and some of this other stuff, like I think it's worth.
Yeah, I'd just be curious. Even maybe like for if nothing else, like a really low dose, like moderate intensity or something. But I don't know.
And another thing to think about with these patients is that there is a lot of like, I guess with pain and chronic treatment of pain, and like a lot of just like providers not willing to prescribe therapies, and just a lot of mistrust that can arise with the healthcare system. And then also like from a cognitive development standpoint, like microvascular strokes, like especially in like the early ages, can like impact cognitive delay and like just openness and willingness to like try and do different things. I'm sure. You can see a lot of delay with some of those things.
Yeah. And the trust with healthcare professionals is a huge one.
Yeah.
Because I feel like there's a lot of judgment sometimes on, these patients are, can deal with enough stuff, on without any of that on top of getting judged for being on all these opioids. And I'm sure they get that at pharmacies too, from filling opioids all the time, which, is unfortunate.
It is very unfortunate. Lastly, health maintenance. She's due for the vaccines we talked about earlier, and then an updated microbiome and a creatinine ratio. But yeah, we ended up making a lot of interventions for this patient. She had a lot of psychosocial stuff going on. So I think the big wins were like getting on her own some non-opioids, getting her back on us antipsychotic, getting her in with psychiatry. I think those were massive for this patient.
She also had Benadryl on her profile. Do you know what she was doing that for? Was that for anxiety or sleep?
Sometimes they'll have Benadryl for like itching.
Okay, just while they're getting their IV infusions or something.
Yeah, or sometimes from their orals. Yeah, they'll have it as well. Hydroxyzine is something that we'll use as well, or even some people will use like the like Zyrtec or anything like that. She did ask for a refill on it, but it kind of like, I don't think we felt super strongly about it. I don't think we ended up refilling it for her.
I was just kidding. The only thing that was thinking with that one is because sometimes if she's using it for either sleep or for feeling anxious or something, hydroxyzine may be a better option, because everybody thinks because it is a stronger antihistamine, and everybody correlates that with stronger anticholinergic effects. And it actually has less anticholinergic effects than something like Benadryl. Although it is a stronger antihistamine. Like it's like the muscarinic receptors versus the histamine receptors, and people oftentimes get those two like overlapped. I've heard that a lot. Like, we can't give hydroxyzine for sleep in an elderly patient because of the anticholinergic effects. If you look up the anticholinergic effects, like as far as the severity of those, like hydroxyzine is actually lower than most of the other first generation antihistamines. Nice. It's just because it's a stronger antihistamine. People just assume all the other potential side effects are also stronger. But it's hydroxyzine also has some activity, some antagonist activity at 5-HT2A, so serotonin 2A, which is what you would want to block to help with some of the anxiolytic effects. Which is why it's a better option, and why psych uses it a lot more so than like Benadryl or something like that. And Cetirizine, people sometimes will use it too because it's just the active metabolite of hydroxyzine.
Oh, really? I didn't know that.
So
I didn't know that.
That's how it all kind of falls back into place, which is interesting.
Mike's just dropping knowledge today.
Yeah, no, you just dropped a buttload of knowledge on me, boy.
I like hydroxyzine for sleep and I mean, you still got to be obviously careful with next day sedation, and there's still the possibility of anticholinergic effects. Don't get me wrong, but I've heard a lot of people just like absolutely shut it down because it's on the beers list or whatever. But it's the lesser of two evils in a lot of cases. And, they give amitriptyline and other things like that. So it's like, why not? At least it's better than zolpidem for a lot of patients.
Right.
If it works, especially if there's an anxiety piece to, the insomnia or whatever they're dealing with. But
Question. Is there, I was trying to actively listen, so I forgot it. So with hydroxyzine, does it provide like any type of like benefit for allergies?
I mean, it's an antihistamine, so I would imagine. Yeah.
Then also, is there like a conversion factor for hydroxyzine to cetirizine?
There may be. I don't know what that is off the top of my head. I just know that's the active metabolite. I would guess, just out of a pure guess, would be 25 to 10.
Okay.
Just because 25 is usually a standard dose for hydroxyzine, and 10 is usually for... I mean, I feel like if I had a gun to my head, had to guess, that would be my guess.
Yeah, I like that.
I'm not 100% sure.
Yeah. Trivia for you guys as far as conversion.
Yeah, somebody looked that up.
Oh, I was going to give y'all something.
Oh, for us?
Yes.
Never mind. Yeah, go ahead.
For converting gabapentin to Lyrica, any guesses for the conversion factor? I know what it is, but...
Well, look at you.
I didn't until somebody told me.
I would guess... I would think it's either 100 to 75 or 300 to 75. Yeah. 300 GABA to 75 Lyrica.
Man, I need like a 1 to something, man. I can't.
Okay.
1 to 4?
Yeah, like
1 to 4.
1 to, I would think 1 to 2 or 1 to 3.
It's 1 to 6.
Is it really that high?
1 to 6. Yeah. But yeah, I learned that. I didn't come out the womb knowing that.
Well, you may have. Don't sell yourself short.
Yeah, I didn't come out the womb knowing that.
Have you guys seen, this is one that I actually got from Bragg a long time ago, but there's a Cochrane review looking at zinc sulfate supplementation with sickle cell patients, and that it can potentially lower the rate of...
man.
Yeah, it's a crises per year. I can't remember which year that Cochrane review came out, but it did show...
I read it.
Zinc sulfate 220 milligrams, I think 2 or 3 times a day. Supplementation can seem to keep the red blood cells hydrated. And cuts down on crises.
Yeah, I've been, my brain, whenever I get into the weeds, I go below the weeds.
Yeah, I hear you, man.
And so I've been looking into the oxidative stress component of sickle cell disease, which is where Indaria, that glutamine, that protein powder works. So I've just been trying to look at, okay, if oxidative stress is a big component of this disease to the fact that a drug got approved that reduces oxidative stress.
What else can do that?
Yeah. Do we need to be assessing like diet, fried foods, tobacco, alcohol? Like, do we need to be increasing like fruits in their vegetable to get like rich antioxidants? There are some patients that swear by like fruit smoothies and say that these make me feel better.
It wouldn't surprise me.
Yeah. Especially if you're eating crap.
Oh yeah, for sure.
But even vitamin C, antioxidant. And so we have a hematologist that I'm like, we're not boys, but we're working on it.
You're working on being boys.
Yeah, we're working on being boys.
Cool. Put in a good word for me.
Yeah. I'm gonna hit him up and be like, yo, what's up with these antioxidants? Can we?
Can we get something?
Do we need a dietitian? Yeah.
No, that's good. Yeah, that's I think there's definitely, I'm sure, something to that.
Yeah, for sure.
Yeah.
Yeah.
It's good stuff, man. This is a good case.
Yeah.
Very good stuff.
Again, I'm not a 10, 20 year professional.
Dude, it's all good. You don't have to explain it. You did great.
2 months, man.
No, man. No, you're doing fantastic. No, like I said, I'm just trying to throw my 2 cents in there as I was seeing stuff as we were going.
Yeah.
But anything else, man, before we jump off here?
No, man.
You good?
Yeah, chilling.
Cole, anything on your end?
No, I think I contributed all that I could.
Cool. It's all good. No, that was fun, man. We definitely need to do another one, especially as you get more these cases. Let's do another one, follow up.
Here's what I really learned is that next time my wife is talking to me and I forget what I'm going to say next, I'm going to say, "Oh, I was trying to actively listen."
That was really good.
Oh,
that was
yeah.
solid. I did like that. Oh, sorry. I was trying to think so deeply about what you were saying that I forgot. I forgot the question I was actually thinking about.
So real though.
I know you are. But that's a good one. I like that. I'm gonna use that too.
Yeah.
All right, guys. Well, I hope that was enjoyable for everyone. If you do have any questions for us or Bernard, you can reach us on social media. And Bernard, you're on LinkedIn and stuff, right?
Yeah. Hit me up.
People can reach out to you there. And definitely let us know if you have any suggestions for topics or any other episodes, that you'd like us to cover. And definitely check out our Patreon account if you want more like structured lecture-based content. It's patreon.com/coreconsultrx. And until next time, Bernard, we appreciate you being here.
Yes, sir. Thanks for having me.
All right, everybody. Y'all have a good night. See ya.
Peace.